Okay, good afternoon and welcome to our Learn and Share conference call. I'm Russ Derry, Director of Education for Epilepsy Foundation of Michigan, and I'll be moderating this discussion. The topic for today is epilepsy in infants and toddlers, and we're pleased to have as our speaker Dr. Renée Shellhaas, who is a pediatric epileptologist with a comprehensive epilepsy program at Michigan Medicine CS Mott Children's Hospital. Dr. Shellhaas, could you briefly introduce yourself, talk a bit about your clinical and research interests, and describe your experience with this topic?
Sure. Thank you so much for inviting me to talk about one of my very favorite topics. So I am a pediatric epilepsy specialist here at Michigan Medicine, and I, for my clinical practice, generally take care of young children who have difficult to control epilepsy or complex epilepsy. And my research interests include seizures in the developing brain. So I have research protocols in newborns with seizures and following those newborns out into their early childhood to see what happens after they've experienced seizures in the first days of life, as well as early life epilepsies, so children who develop epilepsy in the first couple of years of life, and trying to understand what are the reasons for those epilepsies, what are the treatments that might work the best, and what are the implications of those epilepsies. So this topic is near and dear to my heart and what I do every day.
Great. Well, thanks again for joining us. So while people can develop epilepsy at any age, incidence is highest in the very young, before age 1, and the very old. Can you talk about some possible reasons why infants are more prone to developing epilepsy than other age groups?
Sure. So we know that infants are in a phase of just tremendous brain growth and development. And if you think about the way that a baby needs to go from just the very basics, needing to be able to wake up, go to sleep, eat, cry, those sorts of things, to being able to walk and talk and think for themselves over the course of just a few years, there is a lot of development that needs to go on. And as part of that, the infant brain needs to be very excitable, so it makes new connections between neurons all the time. And that's great for development, but it also makes them more likely to have seizures, because what seizures are when the brain starts to fire too synchronously. And so fundamentally just think about young children and infants' brains as more excitable. The brain physiology, so the way that the neurons work, is leaning more towards being able to fire and make connections than to be able to suppress those. And so as a result, we see more seizures in very young children than we do in adults or even older children or adolescents. The other thing that we see from an epilepsy standpoint is that a lot of the early life epilepsies are related to either genetic problems or related to congenital abnormalities or things, birth defects or those sorts of things that babies are born with. And so the symptoms of those disorders may show up earlier in life, and so we see them right away.
Makes sense. Yeah. So can you give us an overview of the most common causes and types of epilepsy in newborns, infants, and toddlers? Sure,
that's a big question.
Yeah. That's why I said overview. So,
yep, exactly. So most of the time when a newborn infant has a seizure, it's actually not because of epilepsy. They are seizures that we call acute symptomatic seizures. So something is going on in that newborn brain that's causing the seizure, and it could be that the newborn has an infection, say encephalitis or meningitis, or that they've had birth asphyxia and they have something called hypoxic ischemic encephalopathy, or things like that. So that there's something that happened to that baby's brain, and as a result or a symptom of that thing that happened, the baby has seizures. And those seizures are not epilepsy. They will happen for days or a week, and then they will go away. And so that's not epilepsy, because epilepsy is unprovoked seizures. Now, babies who have had acute symptomatic or those reactive seizures in the newborn period are at risk for having epilepsy later in life. So the acute seizures go away, but then later on over time, those infants may develop unprovoked seizures or epilepsy. And that's one of the more common reasons for an infant or a toddler to develop epilepsy, is that they had a newborn brain injury. There are, however, about maybe 1 in 8 newborns who have seizures who are taken care of in a big children's hospital like Mott actually has epilepsy as the reason for their seizures. So they didn't have any injury to their brain around the time of birth or after birth. They don't have an infection or anything else going on, but they actually have unprovoked seizures. And those infants, more often than not, have a genetic reason for their epilepsy. And there are a handful of genes, and that list is growing every day, that can explain those kinds of epilepsies. The most common gene would be a gene called KCNQ2. And that can cause both newborn epilepsy that is relatively benign and goes away over time, and a much more severe epilepsy that persists over time, depending on what kind of gene abnormality they have. In infants, sort of a 1 month to first birthday, there's a range of different kinds of epilepsies that we see. The most common, and I think we'll spend some time talking about that, or the most sort of important and one way we discuss the most often, is infantile spasms, or West syndrome. And we'll talk some more about that one. But there are a range of different kinds of epilepsies that children can have in the first year of life. And there's a huge long list, right? So the most, if you look at a textbook, we'll talk about different kinds of epilepsy syndromes like Ohtahara syndrome, or early myoclonic epileptic encephalopathy, epilepsy of infancy with migrating focal seizures. So there are a lot of different kinds of syndromes. But the truth is that there are a lot of infants and children who don't fit tidily into one of those buckets where we have a defined syndrome. And so we call those non-syndromic epilepsies. And far and away, they're the most common. So they may have focal seizures, and we don't know why, or they don't fit in one of the sort of textbook descriptions of a specific kind of epilepsy. I can go on for a long time
Sure.
with this topic, but but that, at least to give you a quick overview.
Yeah, now like in terms of, I guess if you were to look at a pie chart, in general, how many in this age group in early life are roughly percentage-wise have generalized versus focal epilepsy?
Oh, great question. And it depends on which person's pie chart you look at. Okay. But most of the youngest infants will have focal seizures. And the way that I think about that is the really young babies, their brains aren't organized enough to get it together to make a generalized seizure. They don't have the connections between areas of the brain that they need to be able to do that. And so the earliest seizures are going to be focal seizures. They start in one area of the brain. They may or may not spread. As children get older, we start to see more generalized seizure types. And I think about that as the baby's brains sort of grow, mature, and get themselves organized. Then we can start to see the myoclonic seizures, generalized tonic or tonic-clonic seizures, usually in older infants and toddlers rather than in the youngest babies.
Right, and similarly, speaking of pie charts, like in terms of etiology, are we looking at largely genetic being the or structural, metabolic? I guess.
Yep.
How does that?
Great question. So we did a study looking at newborns with seizures of all kinds across 7 different centers in something called the Neonatal Seizure Registry a couple of years back, and we had over 600 babies who had diagnoses of seizures. 13%, so about 1 in 8, actually had epilepsy. And of those, about half of them had a normal-looking brain MRI, and so they had what we called an epileptic encephalopathy, or they had a benign neonatal epilepsy. Of the ones who had an epileptic encephalopathy, 85% had a gene abnormality that was identified as the cause for their epilepsy. So very commonly, that's going to be genetic. And of babies who had neonatal seizures related to a brain malformation, so they had a malformation of cortical development, for example, about a quarter of those had an obvious genetic abnormality. We did a similar kind of study looking at toddlers or infants who had epilepsy onset before age 3, and actually the youngest of those subsets, or the youngest half, about a third of them also had a genetic etiology. So really right now we're sort of moving towards trying to define a lot of these kids' epilepsies based on the gene that causes it. And that's really changing the way that we think about diagnosing the epilepsy, how we treat, and how we sort of classify. And that's what I said, we have textbooks that have long lists of syndrome names. We're starting to move away from those and really trying to look at etiology. Okay. Of kids who don't have a gene, it may be that there's a change in the way that their brain was formed, or they may have had an old brain injury that causes a predisposition to seizures. And there are, sadly, a number of patients for whom we don't know the reason for the seizures. Right. Even though we try hard.
Right. Okay, and you mentioned this earlier, but perhaps the most well-known type of epilepsy in infants is infantile spasms or West syndrome. Could you provide an overview of this as well?
For sure. So West syndrome is it's a syndrome that requires a few different things. One is a specific seizure type called infantile spasms. The second is a developmental delay or a regression. And the third is a specific pattern on EEG called hypsarrhythmia. So infantile spasms is one piece of that, and you can have infantile spasms along with the other things to make West syndrome, or you can have infantile spasms separate from West syndrome. Regardless, infantile spasms are important to set apart from the other kinds of seizures because the treatment is very different from other kinds of seizures. The reasons for the spasms may be specific, and the prognosis after infantile spasms is important to discuss. So what do those spasms look like? Oftentimes described as sort of a flexion of the trunk or sort of crunching forward of the abdominal muscles, and the head may come down while arms and legs may stiffen or stretch out. Most of the time, the movements are symmetric, so the left and right side both may extend or move at the same time, but sometimes it'll be asymmetric, so maybe a baby will have spasms that show up mostly on the right side, and that may be a clue as to why the child has that kind of epilepsy. Things to know specifically about infantile spasms, so you may have a baby who has this unusual movement where their head may come down, their arms come up, and they stiffen just for a second or two. Oftentimes they may have a cry at the end of that, but importantly, infantile spasms don't happen just once. They tend to have what we call a cluster, so the baby may have a number of these individual little seizure or brief seizures in a row, and typically they'll happen as the baby's falling asleep or as they wake up from sleep. So if you have an infant less than a year old who starts to have sort of the same repeated event that clusters or happens in sort of a group of events back to back to back as they fall asleep or as they wake up, that would be a sign to call your doctor right away. And the reason I say call right away, and then when I talk to my families in clinic, I say right away, even if it's the weekend. I want to know if it's a Saturday morning. I want to know because I want you to come in and we'll figure this out. Is that the sooner we can treat infantile spasms, the better the baby's prognosis for good development will be. And too often there's a delay in diagnosis, and that's not good for anybody.
Right, and in terms of seeing a general pediatric neurologist versus a primary care or pediatrician versus an epileptologist, if you suspect that your child might be having. If you suspect
right. No, great question. So, if you think that the baby has infantile spasms, then depending on where you live, right? If you have access to a primary care doctor who's good and can direct you straight on to a neurologist, fantastic. If you don't and you go to an emergency department to be evaluated, that's not a bad place to be for this particular kind of seizure. Do you need to see an epilepsy specialist right away with a diagnosis of infantile spasms? Not necessarily. So a general child neurologist should be well equipped to take care of, at least at the beginning, the diagnosis and initial management of infantile spasms. What do we do for that diagnosis? We need to sort of have the history of what's been going on. We're going to ask about what those events look like. Do they cluster as the child awakens or falls asleep? We're also going to ask about development. So one of the pieces of West syndrome that I talked about was this developmental regression or developmental delay. And typically what we'll see is that as a child develops infantile spasms, they sort of disengage a little bit. So they may lose the ability to do things that they used to do. For example, a child who was able to sit independently and now really isn't sitting as well, or the head control is not as good. Or a child who was very socially engaged, always looking at your eyes, always smiling and cooing and babbling at you, who stops doing that. That can go along with infantile spasms, and the goal of the treatment is really to make the seizures go away, but also to rescue that infant's development. So we're going to ask about development. We're going to look at the EEG. And so I talked to you also about that there's a specific pattern in West syndrome that we look for on an EEG, and that's called hypsarrhythmia. And what that shows us is chaos. So when we look at EEG patterns, there are specific patterns that we look at, and there are normals based on how old the child is. In hypsarrhythmia, the whole thing looks very, very abnormal. The brainwaves are very high in amplitude, so they squiggle all over the page, and they're very disorganized. What's happening in the back of the brain is the same or not differentiated from the front of the brain, things like that. So that's a pattern that any neurology resident, medical student, neurologist should be able to pick out right away on an EEG. And many children with infantile spasms will have that pattern of hypsarrhythmia. Not all will, though, and that can get a little bit more tricky for diagnosis. But over time, what we're finding is that actually it doesn't matter whether or not the child has hypsarrhythmia or this very abnormal EEG pattern. If they have this kind of seizure, infantile spasms, then they need the same diagnostic evaluation and treatment as whether or not they have the sort of hallmark pattern on their EEG.
Okay.
So the other pieces of the other pieces about diagnosis are the examination of the baby, understanding whether they had a history of a brain injury, for example, before that might predispose them to epilepsy. And typically, every baby where we diagnose infantile spasm should have a brain MRI. Again, looking for what's the reason for that particular kind of seizure, and then we look, if we don't have an answer based on a history exam and an MRI, then we look to genetic testing and sometimes metabolic testing, sort of more advanced testing to get a reason. In the meantime, though, we start treatment right away. And I think what you're going to ask is what about treatment? Is that right? Yeah. And so here is a lot of times in neurology, there's a lot of art in what we do, and there's not as much scientific evidence or data that we can fall back on and say this is exactly the right thing to do. Here we're in a place where we do actually have some data, and we know what our options are. So there are 3 standard treatments when we first start treating infantile spasms. One is ACTH, which is an injection of a high-dose steroid. Another is oral steroids, prednisone or prednisolone at a high dose. And we hear about using oral steroids all the time, like for an asthma exacerbation, but the doses we use for infantile spasms are a lot higher. Or a medication called vigabatrin, which is a medicine that's taken by mouth. And there are different reasons that you might choose one of those 3, depending on the infant and what else is going on with that baby at that time. But what we find when we look across hundreds of babies and lots of different centers across the United States, is that if we choose one of those 3 medicines, we're much more likely to have the seizures come rapidly under control than if we choose any of our other seizure medicines. And so the push right now is to make sure that every baby with infantile spasms has a rapid diagnosis and quickly get started on one of the 3 standard treatments.
Yeah, and I guess relating back to the question about who you see when you first are diagnosed, how often do you see people referred to you who have not been put on one of those 3 medications?
It does happen.
Okay.
It's happening a little bit less often now than it used to.
Okay,
but when I get a referral come across my desk that says concern for infantile spasms and they're not on one of those 3 standard medicines, that would trigger me to call the family and say, look, we need you to come right away, even if that means you need to come to the emergency room tonight so that we can get you on the right treatment.
Okay. And just briefly, what's the prognosis, the spectrum of prognosis in terms of infantile spasms?
Sure.
Yeah. Go ahead.
So a lot depends on what the reason is for the spasms. So if a child has for example, they have spasms because they had a stroke and they have a brain injury, we might be able to go ahead and cure that child with either the medicine or a surgical evaluation. We can look at that later in our discussion. And then the child will potentially be rescued and not have ongoing epilepsy. Similarly, the best case scenario is we do our evaluation and we never figure out why the infant had infantile spasms, and those babies have the best chance for having normal development and no epilepsy in the future. Unfortunately, a lot of infants who have infantile spasms will continue to have sort of lifelong troubles. Those will include a risk for epilepsy and epilepsy that changes over time. What kinds of seizures and what kinds of treatment will change over time. And a risk for intellectual disability, cerebral palsy, and other challenges like that. So most often, children who have infantile spasms will have some disability going forward. What we find as we look to the literature is that the soonest we can get spasms under control, the better the chances of a good outcome are.
Okay. So thinking of infantile spasms as an example, seizures in infants can look quite a bit different than seizures in older children and adults. So can you review some of the most common seizure types seen in newborns, infants, and toddlers, and how they differ in presentation from seizures later in life?
Sure. So the youngest babies typically are going to have focal seizures, like we talked about, where they may have one side of the body that stiffens or shakes, or it may be seen just in the face or a part of the body, arm or leg. But infants and toddlers can have the whole range of the different kinds of seizures that we talk about. The infantile spasms we already discussed. Babies can have focal seizures where they lose awareness, or they may stare. They may have some different movements that we may call automatisms, that the fancy word for just saying like lip smacking or picking with their fingers, that sort of non-purposeful movements that go along with staring and unresponsiveness. And we can help try to figure that out of whether this baby is just, or child is just staring because they're daydreaming or looking at the TV, or whether they're having a seizure by tickling the child, getting up, getting in their face to say something silly and see if they respond, that sort of thing. Maybe pinching their nail beds is another thing we do, because they should respond if they're just daydreaming. If we interact with them, if they don't respond, then we're concerned more that that's a seizure. Young children are less likely than older children to have absence-type seizures. Absence seizures in older children, we see sort of the blank stare, unresponsiveness for just a few seconds at a time. That's pretty unusual in a young toddler or an infant. But more commonly that we would see a focal seizure that's going to be a little bit longer, altered awareness, shaking of or or stiffening of one area. They can also have generalized tonic stiffening, so stiffening all over the body, or clonic jerking all over the body. So there's a whole big range.
Right.
A lot of times families then feel very sort of confused and overwhelmed. How do I know what's a seizure, what's not a seizure, especially in their young babies, right?
Right. I remember that myself, working at the Foundation of Michigan with both of my kids when they were babies, watching them sleep. I'm like, well, they're twitching. What's that? They're grunting. What is that? And
absolutely,
there's a wide range of normal movements and behaviors and reflexes and things. So, yeah, can you talk a little bit more about how to distinguish between those?
For sure. And as a parent myself, I had the same experience of looking at my own children and saying, gosh, I'm glad I know better, but I could see why people would be worried. So there are a few things that I look at and talk about with families. The first is seizures tend to be the same thing every time. And so we call them stereotyped events, right? It's the same event every single time. Whereas sort of normal baby movements or even abnormal baby movements that aren't seizures, they'll be a little different every time. This time it was, twitching of both legs, and that time it was some funny sucking movements, and this time it was the arm or that sort of thing. So if it's a different thing every time, it's less likely to be seizures than if it's the same pattern every single time you see it. Most often, seizures are unprovoked, so there's nothing that brought it on, and there may not be a specific pattern, whereas behavior events are more likely to be provoked. So maybe a baby has events related to breath holding spells, and they got mad, and then they take a big breath and they don't breathe out, and they turn a little blue and they look like they're staring, but you can see the pattern every time. So that can be helpful to try to sort out. There are other movements that may be sort of self-stimulatory or sort of repetitive behaviors, especially in children with autism spectrum disorders, and that can be tricky to sort through. Daytime versus nighttime, there are some nighttime patterns or sleep patterns that we know are normal. So night terrors, for example, a child who screams out of sleep and you can't really get their attention, but there's not a sort of typical stereotyped or repetitive movement that goes along with it. So there's a whole range, but talking through with your pediatrician can often help to sort of tease out which things are worrisome and which things aren't. The truth is, though, that sometimes we just can't tell. And in those instances, I may order an EEG to try to capture the event that we're worried about and sort it out that way if I can't tell after careful history and exam.
Right. And I imagine with smartphones now, it's can be very handy of the parent.
Absolutely, and it's
record.
Yes, it's so much easier to get a video now than it used to be. And I know in our health system, and I'm sure in others as well, we have a way to upload a video so that I can look at a patient's video when they have their event of concern, and that can be helpful, especially for things like things that you need to know right now. Is this concerning for infantile spasms? I took a video and I send it to my doctor, and they can look at it and say, oh, yeah, I'm worried about that. Or, you know what, I'm not as worried about it because of this and this and this. So absolutely, if there are events that you can get a video, knowing that sometimes you can't because, there's no warning or they're very brief, that sort of thing. But if you can, that can be extremely helpful.
So you mentioned breath-holding spells. That's one of the things you might have to rule out. What are some other conditions that you typically have to rule out before diagnosing epilepsy in infant or toddler? In an infant or toddler?
Yeah. A lot of times we think about reflux. So in a baby who maybe they have low tone or high tone and they spit up a bunch, they may actually have posturing or abnormal looking movements that are related to reflux and not to seizures. We will talk a lot about, is it a behavioral event, or behavioral staring, for example. When I said hey, can you tickle the baby or give them a little pinch and see if they respond to you. We'll look at that. Things that happen out of sleep, sleepwalking or night terrors. those sorts of things we'll talk through. There are some migraine variants that happen in young children who are not going to tell you my head hurts, and their head may not hurt, but there are some variants of migraine that can mimic seizures as well. And a whole range of other things. But the bottom line is thinking about this. If it's the same event that happens over and over again, I start to worry more about seizures.
Right. So once epilepsy is diagnosed and parents have learned to recognize their baby's seizures, how can they balance the need to track and respond to seizures with the need to actually get some sleep and manage their own stress?
We probably need to ask some parents who've experienced it to give us the best advice. So the things that I tell my parents, first of all, is you're not alone. Although epilepsy, there are a lot of people who think they've never met somebody with epilepsy. Epilepsy is common. And as you actually step back and look, there are other people out there. Connecting with Epilepsy Michigan is my first step for my family to say, look, reach out and at least look on their website and get some reliable information and, call, talk to Russ, talk to the other folks who work in the office, right? And know you're not alone. There are also, if we have a specific epilepsy diagnosis, there are support networks for families and parents for children with specific kinds of epilepsy, for just about every kind of epilepsy you can think of. If you're not sure where to start to look for, where's my group of people with children who have epilepsy, if you can look at the Rare Epilepsy Network, that is run in conjunction with the Epilepsy Foundation of America, and they link multiple different patient support networks. So looking at Rare Epilepsy Network is also a good place to go. On the individual basis, once we have an idea of what the baby seizures look like, if there are particular patterns that we can identify, that can help. But the maddening thing about epilepsy is that it's unpredictable, and I know that it's beyond difficult to figure out how to balance this, wanting to be vigilant and watch your baby all the time, and knowing that you have to live your life. Most individual seizures for a baby are not going to cause harm. They're not going to cause more brain injury, for example, if you missed one seizure. We want to know about them, and we want to get them under control. But if a child has a brief seizure that wasn't detected by the parent, that's not the end of the world. I know that parents are worried about, what's going to happen when I go to sleep and my baby's asleep. First thing is safe sleep for infants is really, really important, and making sure that we're following the precautions that every baby should have followed to avoid sudden infant death syndrome, right? So babies should sleep on their own in a crib or bassinet without anything else in that crib or bassinet, right? No stuffed animals, no bumpers, no blankets for their first year. And they should be put to sleep on their back. And so those are basic general pediatrics, general parenting things that can help our babies stay alive. Babies who have epilepsy, again, as I said before, typically it's the same kind of seizure every time. And so if your baby has only ever had very brief seizures, chances are they're not going to have a very long seizure the minute you turn your back, right? There are some infants who have long seizures, and there, we have to come up with an individual plan for a specific baby for what we're going to do to try to keep them as safe as we can. But most of the time, it's going to be okay, and parents really need to try to get some sleep too so they can function during the day. Right.
And for those who do have seizures that put them at risk, prolonged seizures, for example, or status epilepticus, what technologies or strategies might help to reduce that risk or help to alert parents so that they can get sleep but can also respond to a seizure.
So let me be a little bit careful about how we discuss, because I think it's tricky.
Sure.
The first and most important thing is to try to get excellent control of the baby's epilepsy, right? So working with your doctor to get the right medicine, or if they need a dietary therapy or an epilepsy surgery evaluation, that we get the very best epilepsy care to get seizures under as good a control as possible. The second is to recognize that there are lots and lots of products on the market, and you can spend lots of money to buy monitors and special, watches and this and that. A lot of them promise a lot more than I think they can actually offer, and so there is no perfect monitor, and most of the things that are available are tested in older patients or patients who may have different kinds of seizures. So if you're relying on a monitor that is detecting movement, for example, but your child doesn't have dramatic movement during their seizures, that monitor is not going to work and it's not going to pick up the seizure. So I don't want to give a false sense of security just because you bought something that seems like it should work. But there are some patterns, if you have a baby who very often has their blood oxygen level go down and needs a rescue because they have long seizures, sometimes having a home pulse oximeter makes sense. Usually, though, I tell families to just get a regular baby monitor so that if there's an unusual noise or something like that, they can be alerted and the baby can still sleep in their own area.
Sure. Okay.
So
go ahead. One more thing.
No, it's fine. It's fine.
Oh, okay. Febrile seizures are quite common in infants and toddlers. Can you talk about the different types and patterns of febrile seizures, their management, and how they influence the risk of developing epilepsy in the future?
For sure. So just like when at the very beginning of this, I said, most seizures in newborns are not related to epilepsy. Most seizures in toddlers who have a fever are not epilepsy either. They're febrile seizures. Febrile seizures happen in about 4% of all children. And depending on your ethnic background or your racial background, that risk may be higher or lower. So in Japan, for example, the risk is higher. And children who have straightforward febrile seizures grow and develop just the same as children who never had a seizure in their life. So we consider them febrile seizures a general pediatrics issue rather than a pediatric epilepsy issue, almost always. And I sort of convey that confidence that a child who has a seizure, because in the context of having a rapidly increasing fever and the child was otherwise normal before and is fine again after they recover from their seizure, that child is going to be fine. The different types and patterns of febrile seizures, so there's simple febrile seizures, which means that the seizure was generalized in onset or both sides of the body are involved at the same time, associated with a clear fever, and that fever could happen just right after the seizure happened, so it doesn't have to be that the child had a fever all day long before the seizure happened. In an otherwise typical child whose seizure lasts less than 15 minutes. And 15 minutes is a really long seizure. It's a long time to watch. But up to 15 minutes, we call that a simple febrile seizure. And there's no need for lab testing, EEG, imaging, anything like that. It's reassurance. There are complex febrile seizures, and those are febrile seizures that don't meet some of the criteria for the simple febrile seizure. So maybe they're asymmetric, so it's one side of the body and not both, or they happen multiple seizures within a single 24-hour period, or they happen and they're longer than 15 minutes. Complex febrile seizures increase the risk of later epilepsy a little bit, but it depends on what kind of complex febrile seizure they are. So if I hear that a child who was otherwise well had a focal complex febrile seizure, so that it involved shaking of just one side of the body, and it only happened once and the child's otherwise totally fine, I'm still going to be very reassuring and not worry too much. If, on the other hand, I hear a child young, maybe 6 months old, and they had a focal febrile seizure that lasted for a whole hour, then I'm going to say, gosh, that was pretty long and that infant's pretty young. I'm going to think about, it could just be regular bread and butter febrile seizures. It could also be the first sign of an epilepsy syndrome called Dravet syndrome. And there's a lot of push of when do we think about Dravet syndrome? It's a specific kind of epilepsy that often presents in infancy with long febrile seizures that involve just one side of the body. So if that happens once or twice, I'm going to worry about Dravet syndrome, and then an epilepsy specialist should get involved. Otherwise, most of the time, there's no specific epilepsy-type management. It's all about reassurance about if there needs to be a rescue medicine because a child likes to have seizures that are longer than a few minutes long, and we want to be able to stop that seizure. We may talk about rescue medicines, but daily medicines to prevent febrile seizures are not necessary, and we have to recognize, too, that the febrile seizure might be the very first sign that a child is sick, and so we can't feel guilty if we didn't know that the baby was going to get sick and had a fever, and they showed up with their febrile seizure. Does that make sense?
Yeah. Okay. So we talked a little bit about prognosis, but can you review some of the factors that tend to predict a favorable prognosis and some that maybe predict a less favorable prognosis? I know it depends largely on the individual and the type of epilepsy, but generally speaking, what are some of those factors that...
Sure thing.
Yeah.
So I think the most reassuring thing that I can see when I look at a child is what does their development look like before they started having seizures and after they start having seizures. And if that child's development is really normal, then the chances are they're going to continue to be normal. And so that should be reassuring. If we can get to what is the etiology, what's the reason for the epilepsy, that will give us a lot of information about what to expect. And sometimes we can get an etiology where we can say, you know what, this fits with this pattern and we think the child's going to be fine. And sometimes we get a pattern and an etiology where we say, you know what, we're worried about this and we're worried about specific problems in a child's development. The other sort of big picture pattern that I look at is does the child have persistent seizures? We've tried a couple of medicines and we're kind of not winning. Still having seizures or having an increasing number of seizures, then I'm going to start to worry that we're going to lose ground from a development standpoint.
Right. Okay. So one of the biggest concerns of parents is the potential impact of the epilepsy and whatever the underlying cause is, the seizures, including status epilepticus, and the treatment on their young child's development. Can you talk about the relative impact of each of these on brain development and what parents can do to potentially minimize that impact?
Sure, and I think that's the biggest question, right?
Right.
Is what in the long term, how is my child going to be? And it is often very hard to tease all of these things apart.
Sure.
If we know what specific kind of epilepsy a child has, then we can look and see what have other children, how have other children done when they've had this kind of epilepsy. And so that underlying cause or the epilepsy syndrome can really help with trying to understand the impact of having that kind of epilepsy. And that's why we try to look and say, okay, well, beyond saying it's focal epilepsy or generalized epilepsy, does the child have Dravet syndrome, or do they have West syndrome, or do they have epilepsy related to a specific gene? Can we look at Rare Epilepsy Network for support, and can we try to understand the impact of the seizures themselves? Like I said earlier, a brief seizure that doesn't result in an injury, so doesn't cause the child to fall down the stairs or something like that. A brief seizure isn't going to hurt the child's brain. Having long seizures that go on for hours is not good for anybody. We definitely want to avoid that. But a brief individual seizure isn't going to hurt the child's brain. Having said that, I just said that I'm concerned about a child who continues to have persistent seizures even though we're trying treatment, and knowing that, and the reason for that is that's a sign of sort of the underlying trouble that's going on with that child's brain. So we may see that a child's development slows down if they're having more seizures or their seizure burden goes up, right? So we think about the impact on what they can do. If a child has a seizure multiple times a day and maybe each time they need a nap in order to recover, they're not going to be able to participate in as much interaction time with parents, or if they're going to preschool, those sorts of things, as a child who has fewer of those kinds of disabling seizures. And so we want to try to reduce the number of seizures as best we can. The impact on the treatment, I think, is also really important. We want to give as much treatment as necessary, but not any more than that. And our initial, when I first see a child with a new diagnosis of epilepsy, my goal is that we're going to give a treatment and there are going to be no more seizures and no side effects from that treatment. And very often we can get there. However, if that first treatment doesn't work, then we're going to move to the next one. And we'll move to the next one until we can figure out the best either single medicine or combination of treatments that balance the control of seizures and the side effects from medicines in order to give a child the best chance for development. And that's going to vary depending on the individual child and their circumstances.
And is there any evidence to suggest that long-term use of anti-seizure medications has any impact on development?
So it's very difficult to really tease that apart. And so when I say, we want to give as much medicine or treatment as is necessary, but not any more, there are some unknowns. There are studies in rats where they give seizure medicines and find that there are influences of the medicines themselves on the developing brain, and that obviously is a cause for concern. But those are studies of rats, and children are not rats. And they're not the rats don't inherently have the kinds of epilepsy that our patients have. So it's a little bit hard to sort of directly compare. We don't want to give medicines that's not indicated. So we talked a little bit about in febrile seizures, there's no reason to give a medicine every day to prevent febrile seizures. And we know that from a study where they did give medicine every day to try to prevent febrile seizures. They gave phenobarbital, and the children who were treated with phenobarbital actually had slower development than children who were not treated with phenobarbital. So we don't want to give medicine to a child who doesn't need it. On the other hand, we don't want a child to have uncontrolled seizures because they are not getting treatment for their epilepsy.
Right. Okay. So when infants and toddlers with epilepsy are not meeting developmental milestones at the expected time, can they sometimes catch up once seizures become better controlled or medications can be reduced?
Sometimes, yes. So our kids, for example, are infants who present with infantile spasms, and they've had a developmental regression, that child who sort of disengages from their environment or isn't able to do things that they were able to do before. One of the things that we look for is, as we pretty aggressively treat infantile spasms, does the development start to come back? And that's the reason that we're aggressive about that particular kind of epilepsy. Also, children who are just having very frequent seizures, when their seizures come under better control, we will often see that their development gets better. I still worry about every infant or toddler who has epilepsy. I worry about their development. They're all going to be at risk for some type of developmental delays, and some of those are going to be things that catch up and some of them aren't. And so I think it's really important to be plugged in with services like early on, to have objective sets of eyes on a child to evaluate their development and provide services should they need them, like speech therapy or physical or occupational therapy, and to really continue to engage that child, talking to them as much as possible so they hear language. You can't learn language if you don't hear it, things like that. in the home all the time. Families often will talk to me about, well, what about, is it the medicine, and are medicines making the child have a developmental problem that they wouldn't have otherwise? And that's a tricky one, depending on what kind of epilepsy, what kind of medicines. If the medicine is too sedating and the child can't be awake and alert and engaging with their environment, then that's not good for them either. But but that's a balance that is really an individual balance that the doctor and family need to work on.
Right. Okay, so obviously babies need less anti-seizure medication than larger humans, but can you talk about some other unique considerations when putting together a medication regimen for an infant or toddler?
Sure. So it's interesting that babies and infants and toddlers, although you might think they should definitely need lower doses of medicines than an older kid or an adult, sometimes their bodies metabolize the medicines faster than an older child or an adult might. So sometimes on a sort of per pound basis, they get a higher dose than you might expect.
Oh, okay. I guess not obviously.
So,
I made an assumption.
So it's not always the same. Yeah, exactly. So because their whole body is young, their metabolism is sometimes different, and it may also depend on what other medicines they need to take, things like that. We'll think about a whole bunch of different things as we make a decision about what medicine or treatment to choose. First, looking to see, is there scientific evidence to say that one treatment is better than another for this particular child's kind of epilepsy? And a lot of times in child neurology in general and in epilepsy, pediatric epilepsy specifically, we're working on very little data and we need expert opinion, and that's where, making sure you've consulted with a doctor who really knows their stuff is important. But like we said with West syndrome or infantile spasms, there are 3 specific first-line treatments, and we're going to go to those. For some other kinds of epilepsies, there are also specific treatments that make sense. But for a lot of the time, we don't have a randomized controlled trial that says, treatment A is better than treatment B. In that case, then we need to look at what kind of seizures are we trying to treat? Are they focal seizures? Are they generalized seizures? What kinds of formulation does the medicine come in? Do we need a liquid for a baby who no way are they going to swallow pills, for example? And how often do we need to give the medicine? Does that medicine have drug interactions with any other medicine that the child needs to take? So things like that. Are there other medical conditions that we need to take into consideration? For example, does the child have a problem with their liver or their kidneys that would change the way they might metabolize a drug? And how old are they? So there's some medicines that we feel more comfortable prescribing to older children than we do to younger children. The other thing that we'll think about is the first line is usually always a medicine you take by mouth, and usually the second treatment also. But after that, dietary therapies can sometimes be a great option. And for young infants who don't know how much they might love chocolate chip cookies or Halloween candy, it can sometimes be easier to start a very restricted dietary therapy like the ketogenic diet than for a school-age child. So we may look to that sooner for a younger infant.
Right. And are there, speaking of the ketogenic diet, are there particular indications where that would be thought of even earlier in the process? And then are there any adverse effects that are unique to the age group, or other than the ones that anyone might experience with the ketogenic diet?
Sure. So I think about the ketogenic diet for any child for whom 2 medicines for their epilepsy have failed to control the seizures, especially if they're not a candidate for epilepsy surgery. I'll also think about ketogenic diet soon for a child who's dependent on a G-tube for their feeding. So if they need formula through a tube feed, it may be relatively straightforward, with a dietitian and a medical team to transition to a different formula that is a ketogenic formula, and the child themselves won't experience anything different other than they're getting fed through their G-tube with a different formula. There are some metabolic disorders that the one treatment is ketogenic diet. So those will be identified quickly, and you'll move quickly to, for example, GLUT1 transporter deficiency is one, where the right treatment is ketogenic diet, and we're just going to go right there. But usually we've tried 2 medicines, they didn't work, and we need to get under better control. Let's try the diet. For infants and toddlers, the diet can be very effective, but you need to be very careful about monitoring a few things. First is when we use ketogenic diet, we are controlling every calorie that goes into that child's mouth. Now, if I'm having a day where I'm just extra hungry, I'm going to go to the fridge and eat extra food. But an infant or a toddler who's extra hungry and can't tell us, they may just be extra cranky because they're hungry. And so we have to monitor carefully their growth and their behavior. Are they always hungry? Then they need some more calories, and we got to work with the dietitian to keep up with that. We're going to watch their growth very, very carefully, and we'll typically see back an infant on the diet at least every 2 months to watch their growth and adjust their calorie needs and their nutritional needs carefully to make sure that we're supporting them as they grow. When we first start the diet in the youngest infants, we're very careful about hypoglycemia, low blood sugar, or ketones getting too high too quickly. So we're watching very carefully, but with good teamwork, we can do this in a safe way. Be very effective for a lot of kids.
Great. So what are you mentioned surgery as an option. Mm-hmm. What are the unique risks and benefits of epilepsy surgery in infants and toddlers?
So the obvious thing is they have smaller heads and smaller brains. And so the risk for surgery in the very youngest infants is higher from the surgery itself. It's just technically a harder thing to do. And so typically we will try to bridge a newborn infant or a very young infant for at least a few months before we'll do an epilepsy surgery, if we can, just to make the surgery itself safer. Anything about epilepsy surgery, we're weighing the risks of the continued seizures that we're having right now versus the risk of removing that area of brain. So if we have a child who's having seizures that are coming from an area that controls movement, for example, we may cause them to have decreased movement in the other side of the body if we take out that motor area. The advantage for a young child is that they have the opportunity to rewire. So if they have the rest of their brain that's relatively healthy, but just one area that's causing seizures, they may be able to compensate for that better than an older child or an adult who would have a similar kind of surgery and might not recover as well. So we like to try to do, if we need to do a big epilepsy surgery, we like to try to do it sooner rather than later once we get outside those first months of life when it's technically most challenging.
Right.
There are some good data to show that for children who need epilepsy surgery, getting it done sooner, again, rather than later, actually results in better development because the seizures get under control faster. And so in the long run, they're better off. You want to be careful that you've gone to an excellent pediatric epilepsy surgery program, had a really careful evaluation to make sure that the right surgery is proposed.
Okay. Can you talk a little bit about seizure response planning and rescue medications? Because a lot of babies end up going to daycare, and how do we make those or help those daycare personnel to be comfortable and be able to care for the infant or toddler with epilepsy?
Sure. So I think it's not realistic to say that the daycare is ever going to be completely 100% comfortable.
Sure.
Right? But none of us are comfortable with seizures that require a rescue, and that's okay, but we do need to plan. And for our patients here, we provide a seizure action plan with every clinic visit, and we update that every time that we see a family. And that seizure action plan will include basic first aid for seizures, what do you do for this, and that would be basic first aid that you would apply to just about anybody with a seizure. Are there any specific things that this specific child needs when they have a seizure? Know that they have a specific pattern. And then do they need a rescue medicine? And if so, which kind of medicine? And at what point in a seizure would you give the medicine? For toddlers 2 years old and older, rectal diazepam or Diastat has the FDA indication for seizure rescue. We will sometimes use that medicine in younger children if they have a pattern of having prolonged seizures that need a rescue, because it's easily packaged, easy to administer, and safe. For our very youngest babies, we may have a rescue plan that involves alerting emergency medicine, medical services, because there's not a safe choice that we can give in the daycare and or at home. Okay. But most of the time we can have a backup medicine to give should a seizure be longer than we're comfortable with. And what that duration is going to vary. We usually draw the line at 5 minutes. If a seizure's been going on for 5 minutes, they need a rescue. But there are some children who, if it goes on for 5 minutes, they always go on for 30 minutes, and maybe we need to intervene sooner. But I think every baby who has epilepsy, there should be a clear plan, not just for daycare, but what if it's, staying at grandmother's house, or it's just being home in general. What are we going to do if this child has a seizure? What are we going to do if this child has a seizure outside of the usual range of what their seizures look like?
Right. What's the earliest that you would prescribe or consider prescribing intranasal midazolam?
Oh, good question. We certainly do prescribe for young infants. I don't know that there's a specific cutoff, but intranasal midazolam can be a great option. I usually will use it in children who've tried rectal diazepam and it hasn't worked for them for whatever reason, or it's not feasible to give to them, just because it's easier to prescribe and administer rectal medicine for an infant, right, rather than having to use needles and draw up a dose and that sort of thing. And but we certainly can use it in toddlers, okay, and do that on a regular basis.
Great. So given the time, I'm not going to delve into all of the other types, the hundreds.
Right.
Are there hundreds? There probably are close to that. But,
there probably are, yeah.
But are there, just to kind of revisit this, are there specific guidelines or recommendations regarding when an infant or toddler should be seen by an epileptologist at a comprehensive epilepsy center?
Sure. I look at infant epilepsy as an emergency and a special situation, special care situation. The sort of official guidelines about when anybody with epilepsy should be looking for a comprehensive epilepsy center include having gone through 2 medicines and having those medicines fail to control the seizures. But for infants and toddlers, it's not just about the seizures, it's about rescuing development. It's about making sure you get the diagnosis right, the reason for the diagnosis right. And so this may seem extreme, but I sort of look at if a child presented with cancer, we wouldn't wait for the cancer to spread before we sent them to a cancer center. So if a child presents with epilepsy in the first year or 2 of life and they're not immediately controlled, I would think pretty hard about sending and going to an epilepsy center right away. Now, if going to an epilepsy center straight away means that you're going to have to wait for months and you have an option to see a general child neurologist first to get started, I would absolutely do that. But I would start thinking about going to an epilepsy center pretty quickly.
Right.
Does that answer your question?
Yeah, absolutely.
Yeah.
And in terms of genetic testing, how often is that used nowadays? Obviously, we're learning a lot more day by day or month by month about the potential role of genetics in epilepsy. Is that something that's done fairly often now for infants and toddlers if there's a suspected genetic cause?
Right. So I think one of the things about going to a comprehensive epilepsy center is it's oftentimes we look at that and we say, well, it's referral for epilepsy surgery, but it's really about much more than that. It's about getting the right diagnosis, and epilepsy genetics is one of the elements of getting the right diagnosis. So we are moving to genetic testing for most of our very young patients with epilepsy, unless there's an obvious reason that we know of that's causing their epilepsy, and we're finding that gives us a diagnosis quickly. There are different kinds of genetic testing, and which kind will depend on the family's situation and the child's situation. If we are going beyond testing for specific epilepsy genes and we're looking at whole exome or whole genome testing, we need to do that in conjunction with genetic counseling and a clinical genetics clinic as well, and so we'll coordinate that if we need to. But we can start with some basic genetic testing within the epilepsy clinic.
Okay.
We work hard to make sure we get our insurance coverage and authorization and that kind of thing, because those tests are expensive, but they can definitely guide our management, and so I think it's part of sort of the comprehensive epilepsy evaluation.
Great. So before we open it up for questions, do you have any closing thoughts on the topic that you'd like to share?
So I think I would say that I recognize it's very scary to have an infant or a toddler who has epilepsy. But again, starting back where we began, families are not alone. We are at a point in neurology and in epilepsy specifically where there are new treatments that are coming up, new ways that we can evaluate and get the diagnosis and understand what's going on with this disorder. I often say to my families, even if the seizures have continued, we're not giving up, because there are lots and lots of options, and we'll continue working with families to try to figure out the very best way to get seizures under control, the very best way to understand why the seizures are happening, and try to help a child reach his or her potential, whatever that may be.
Great. Thank you so much. All right, well, let's open it up for questions. Okay, who would like to get us started with a question?
I would. This is Marissa, and I want to find out what's the youngest that a little baby can have the genetic testing. My daughter that lives here, she has one daughter that's 14 months old, and then she's expecting again, and the baby is due in July. And since I've had seizures for almost 20 years now, I just wanted to find out what's the youngest that, a baby can be genetically tested.
So great question. I think it depends on the reason for the testing. So if you're worried that your child or your grandchild may develop epilepsy because you have epilepsy, you're going to start with figuring out what the reason for your epilepsy is. And so if we know that your epilepsy is due to a specific gene, then we can watch the baby to see if they might develop seizures and test them sooner. But typically if a child is fine, so baby's born and looks good, we would not do genetic testing if they don't have symptoms of a problem. Same thing for brothers and sisters of children with epilepsy. We do not recommend genetic testing if those brothers and sisters don't have symptoms of the disease. They can make their decisions later in life, but there's no youngest age that we can do genetic testing if a child has seizures. Right, so in a newborn period, if they have seizures, they can do genetic testing. Okay.
All right. Thank you.
And in general, Dr. Shellhaas, the overall risk of inheriting epilepsy from a parent is fairly low, right?
It is fairly low, exactly. So the overall risk is going to be low, and that's part of the reason that we say we're not going to just go ahead and do testing on every person with epilepsy's children.
Right. Okay, great. Other questions?
you.
Hi, Dr. Shellhaas. This is Pam. I have a question in regards to the ketogenic diet. I have a grandson that has infantile spasms and has also been diagnosed with epilepsy, and my grandson's epileptologist is now talking potentially ketogenic diet. I guess what are, for lack of a better term, like success rates when a child or an infant is put on the ketogenic diet?
That's a great question. So we actually, just in the last couple weeks, have been looking at what our success rates are here at Michigan Medicine for children with infantile spasms put on the diet. And what we find is that up to a quarter to a third of those babies with infantile spasms have become spasm-free when we put them on the ketogenic diet, which it's not perfect, right? But if we try another medicine, it's more like 2 or 5% become seizure-free. So the ketogenic diet can offer a better chance of controlling the seizures than adding just another medicine. So I think it's definitely worth thinking about for children who've gone through a couple of standard therapies.
Well, I like those odds better.
Yes.
and then adding another medication to the regimen. Thank you.
Sure.
And that would, to clarify, that would be tried after you tried the standard treatments if those weren't fully controlling the seizures.
So for almost every child, I wouldn't move to a dietary therapy until we've tried 2 standard treatments.
Okay.
There are some exceptions to that rule, but typically 2 standard treatments first.
All right. Other questions? Okay. Does anyone have any?
Hi, Dr. Shellhaas.
Yeah, go ahead.
Yeah, I can. My name is Renee. Also, hello. And I wanted to ask, how can we best be supportive, maybe those of us who might be working with families who are going through these kinds of experiences? Because I know I'm sure there is a great deal of concern about developmental delay or continued disability. So, how do we talk about that in a way that provides hope for those families? That kids with disabilities certainly go on to live very meaningful lives, maybe with some more support. And to try to ease some fear, both for the parents who may need that hope, but also sometimes I think kids can internalize some of that fear. And how do we talk about developmental delay and disability in a way that has some positive framing, not only the fear? Yeah, how do you do that?
Great question, and I think you're absolutely right. So I never want to take away hope, because every time that I am 100% sure that I know what's going to happen with a child, I find that I'm wrong, right? And kids are amazing, and they go beyond our expectations all the time. So we want to give every opportunity for a child to reach those developmental milestones. If they need support, whether it's therapies, getting into other specialists to support their development, if it's just enriching what happens in the home, we want to do that as early as we can. We want to make sure that if, for example, a child starts to have symptoms that are consistent with autism, for example, we want to get those evaluations done right away, because there are specific therapies we can do that will hopefully help them to overcome some of the obstacles associated with autism. So definitely talking about them. I think trying not to, making sure there are no secrets. And when I see patients in my clinic, there are no secrets. If I'm worried about the baby, I'm going to say I'm worried about the baby. But I also want to hear a family's worries. Maybe one family is most concerned about one aspect of the development, and another family might not find that is as important. Some families are very focused on will my child walk. Others are more focused on will my child talk. So we need to figure out individually what are our family's priorities, what are the things they're most worried about, and where can we intervene to try to support a child in those domains.
Thank you.
Great. Other questions? Okay. Does anyone have any experiences you'd like to share as a parent or a grandparent of a baby with epilepsy? Like how you deal with like we talked earlier about balancing the need for vigilance with the need for stress, or reducing stress and getting sleep. And does anyone have any experiences that they'd like to share, or resources that you've used in dealing with this that have been helpful?
This is Pam again. As I indicated before, my grandson has infantile spasms and epilepsy. Unfortunately, my daughter wasn't able to join on the call today, but I do need to reiterate what Dr. Shellhaas said earlier in regards to baby monitors. I know that when my grandson had his first seizure when he was 3.5 months, my daughter basically did not sleep a wink until they did, in fact, get a baby monitor, and that did, in fact, give her some peace of mind so that she could keep an eye on Caleb while he was in his own crib in his area as he should be. So if that is something that others may find helpful, I wanted to make sure that I absolutely gave that knowledge. Also, in regards to rescue medication, Caleb is now 11 months, and we were actually just recently given his script for Diagnostic. And I know that this was definitely a sense of relief for my daughter and son-in-law to make sure that we had that seizure action plan in place and that there was something that they could do if the need did arise. So I guess I do have a question, Dr. Shellhaas.
Yeah.
What is the youngest age that you have given a rescue medication?
Oh, good question. So it depends on which rescue medication and which kind of seizure.
Okay.
But
okay.
But I certainly have prescribed Diagnostic for children less than a year. I have to be a little careful where it comes off of sort of outside of the FDA indication. The truth is that a lot of medicines that we prescribe are outside of FDA approval and indications. But even if Diagnostic's not an option, there may be other medicines that are options for our youngest babies. And the reason that we might not want to prescribe for the youngest ones are Diagnostic we can only give the lowest dose that we can administer is 2.5 milligrams. And if that's too much for a very tiny child, we don't want to give them too much. But so there may be other medicines that we can give for smaller children. But at least having a plan, I think, does give peace of mind and also empowers families to at least know what they can do. I will say I loved your comment about the peace of mind that came with having a baby monitor. And I have had many times when I've been humbled in my practice, and one of them was an older child, actually, who for her 16th birthday, she'd had epilepsy for her whole life, asked for a baby monitor so that she could sleep in her room by herself. And that just reminded me how important it is to try to be able to give some sense of normalcy and foster independence as children get older. And so sometimes that baby monitor can actually be freeing for an older child too.
Great. Now, in terms of Diagnostic, is that typically only given if the child is at risk for status epilepticus, or is it being given more often in just prophylactically, just as you have it just in case you need it, and here's the circumstances in which you use it?
I think it depends a lot on the individual circumstances. So certainly if a child has a history of status epilepticus, they need to have a rescue medicine in place so they can give that medicine right away should they have another long seizure. If a child has not had status epilepticus, they've never had a prolonged seizure, then I think, and I talk with the families and say, look, your child is maybe younger than what we would typically prescribe Diagnostic or another rescue medicine for. We have to accept that that's that raises the risk a little bit. Where do you live? Are you right around the corner from a children's emergency department where the best thing would be to just show up there, or do you live far away from the nearest hospital where it really does make sense for you to have medicine available in your home to use right away? So there are different kinds of considerations that we may take into account. What else is going on with the child? Do they have other medical conditions that would make using a benzodiazepine more or less risky, balanced with the risk of a long seizure?
Right.
And I have some families who say, you know what, I don't care, I'm just going to call 911. And I have other families who say, please, I just having it so I have it in my purse gives me peace of mind and lets me feel comfortable about going about the regular things that our family needs to do.
Okay, so that's good to know that parents, if they would like to have that for peace of mind, can talk to their neurologist.
They should absolutely talk with their doctor about
it.
it. Absolutely.
Yeah. Okay.
Absolutely.
Great. All right, we have about 5 minutes left. Does anyone else have any questions? Okay, well, I think we will go ahead and wrap it up. And thank you so much, Dr. Shellhaas, for a thorough and very enlightening conversation. And hopefully this was helpful for everyone listening and for those listening to the recording in the future. So thank you so much. Again, for more information about epilepsy, please feel free to contact Epilepsy Foundation of Michigan by calling us at 1-800-377-6226 or by visiting our website at epilepsymichigan.org. Our next Learn and Share conference call is on headache and epilepsy on May 1st from 6 o'clock to 7:30 p.m., so hopefully people can join us for that. Again, thanks so much, Dr. Shellhaas, for a great call, and thanks everyone for joining us today.
Thank you so much. Okay.
Thank you.
Thank you.